This isn't too bad. Okay. So, let's talk about antibiotics. As you all know, sometimes your immune system doesn't work. Sometimes you get an infection. Normal flora doesn't. You kind of keep that infection at bay. Your immune response doesn't. So then you end up getting, if you have a bacterial infection, you end up getting an antibody. So they're going to, and you know this because you've done the Kirby virus test already. So these antibiotics are going to either kill the bacteria, or what they're going to do is they're going to, I mean, we haven't talked about it like this, I guess, yet. They're going to keep the number of bacteria that's in your body that's causing the infection at a set amount. Why do you think that matters? It's not getting rid of it. It's still there. It just doesn't let it proliferate anymore. Why is that? What's the point of that? Control infection. But what's that allow your body to do? It allows your immune system the opportunity to actually fight it off before there's more bacterial cells than what it can handle. So it kind of just keeps it at a set amount so your immune system has a chance to actually wipe it out. So those are how bacteriostatic antibodies work. Bactericidal antibodies are easy to understand. It just kills them. So the immune system doesn't have to do anything. It wipes them out. When we talk about antimicrobial agents, sometimes you'll see me, I think, hedge what I say with this stuff. You're talking about an antimicrobial. That can be an antibiotic, it can be an antifungal, it can be an antiviral, it can be an anti-helminth medication, that's for worms, antiprotozoals against protozoans. So that encompasses all of it. But we're pretty much just going to talk mainly about antibiotics today. There's a lot of naturally occurring ones. There is a bacterium called Streptomyces that makes dozens of antibiotics. Some fungi make antibiotics. We talked about penicillin makes penicillin. And a lot of these antibiotics we use are either naturally occurring or we've taken a naturally occurring antibiotic and we've added a carboxyl group to it or a hydroxyl group to it, added some kind of functional group. And when you add different functional groups and you change it over a naturally occurring antibiotic around a little bit, it's referred to as semi-synthetic because you muck with it a little bit. That changes the functionality of it, so it might make it effective against bacteria it wasn't effective against before. So that's kind of how you do that. And that is the only question I think that was from that applied microbial on the exam. Again, Streptomyces makes more antibiotics than what's even listed up here. It makes a bunch. You don't need to know what makes what. So different bacteria make some different things. Different bacillus species can make different antimicrobials. And remember, they make these different antibiotics, these antimicrobials, because a lot of these things come from places like the soil. So they used to compete with other microorganisms for food, essentially. We just exploit these to treat infection. Different fungi make different antibiotics. Difference between broad spectrum and narrow spectrum. Have I talked about this in here or no? Broad spectrum means it treats a broad array of different things. Narrow spectrum means it treats a narrow spectrum. This is some things. So what's that mean? Broad spectrum antibiotic might be something that's just like, oh, this antibiotic is effective against all gram-positives. Narrow spectrum antibiotic is, oh, this antibiotic only works against tuberculosis. So narrow versus broad. When you treat a patient, this comes into play because what you do is when somebody comes in and they have a really nasty infection, for the first couple of days, you don't have lab results back. You don't know what bacterium they might be infected with necessarily. You might have a hunch, but you don't know for sure. You also don't know if that bacterium, what it's resistant and sensitive to, what antibiotics for sure. So what you typically do is you give them a broad spectrum antibiotic that's going to have an effect against all the things you think it might be. So it's going to be broad coverage because you don't know what's going on. After a couple of days, when you get the lab results back, you can take away that broad spectrum antibiotic and switch somebody to a narrow spectrum antibiotic with just treating what they have. And what that does is it allows us to then use the broad spectrum antibiotics against infections so bacteria don't become resistant to it. Because if you just give everybody broad spectrum antibiotics, you're going to eventually start selecting for bacteria that are resistant to them, and then you can't use them anymore. So we usually just reserve the broad spectrums. Well, really, it's supposed to reserve the broad spectrums for things like that. Does that happen in practice all the time? No. But that's the way it's supposed to be. Broad spectrum, you do something called antibiotic timeout, where you evaluate the lab results, and then you switch to narrow spectrum, and that's the narrow spectrum is considered a targeted therapeutic, so it's targeting one specific thing. What else do I tell you? You ever heard the word antibiogram in here? Real quick. So, in the hospital, at least annually, if not more than that, there is a table that comes out called an antibiogram. So there'll be the different bacteria that you see in the hospital. I'm not going to touch on this. I just want you to be familiar with it, especially if you have it later on for other things. You get a table that has the bacteria listed on one side and the different antibiotics used to treat bacterial infections along the top. And what you have in here are numbers. So say bacteria 2, you never use C to treat it. It's just not indicated. You'll just have that box grayed out. But what you might see in the other boxes are things like this. I'm literally just making up numbers. And what this is the different bacteria they saw in the hospital. It's the percent of those bacteria that are resistant to those different antibiotics up here. So when you're giving somebody a broad therapy, and empiric, referred to as empiric therapy when they first come in the hospital, you don't know what it is necessarily. So you come back to this chart, I was like, okay, so you look at this, somebody's infected with whatever bacteria number 2 is, let's say it's E. coli. Well, you're not gonna give them antibiotic D because 100% of the people that came in with that kind of bacterial infection, the bacteria was resistant to it. You might want to give them A because you haven't seen any resistance to that. So this is how you start. Does this work always? No, but it helps a lot. Does that make sense? So that's kind of how you start to figure it out. So that's what empiric therapy as opposed to targeted therapy. So broad spectrum versus narrow. Yeah, what's up?
I think there's a lot of people, I saw some people saying that people haven't been able to step through that. It's like their citing medication for forces, that people use it as a advocate. Yeah. So they use it, and somebody was saying that it's actually going to be a very long-term effect for them if they do need an antibiotic in the hospital. And I was just curious, like, how many antibiotics do you feel like they would cancel out if they keep using it?
Ivermectin's not an antibiotic though. Ivermectin's like a horse dewormer.
Yeah, it's a.
I mean,
Test on humans, so we don't know what'll happen for the people that are taking it else.
I knew a dentist, don't ask me about this, but there was a dentist somewhere that was giving people ivermectin for COVID-19. So there's been some trials, there were some trials that were done with it. The problem with those trials are they weren't necessarily very well controlled, and they had like a test population like 3 or 5 people. That's not enough to tell anything. So, I mean, that's probably not going to push resistance to anything or select for resistant bacteria because you don't use that to treat bacteriological infections. And most people in the United States aren't exposed to like helminth infections because a lot of the helminths and protozoal infections and some bacterial infections, viral infections are spread fecal to oral. So a lot of helminth infections are spread fecal to oral. You're probably not going to be exposed to that anyways. I mean, it is a drug. There are side effects. Eventually, if you take enough of it, you will probably start to recognize some of those side effects. Can't remember what they are for ivermectin. I'd have to look at the label, but I wouldn't want to live on them. I mean, it is of course people are. Usually anti-helminth drugs tend to make you sick after a while. This is why sometimes if you give, like for medication to a dog, sometimes they get nauseous, sometimes they get sick. That's an artifact, that's one of the side effects of those kind of anti-helminth drugs. I wouldn't want to snort ivermectin all the time. That wouldn't be great. We talked about this. You don't need to know all this. Don't. That's cytokills, static inhibits. This is a little bit more important. So, selective toxicity. So, ability of the drug to kill or inhibit a pathogen while damaging the host as little as possible. So, you want to give somebody, let's talk about antibiotics again since we're bacteriologists, but you want to give somebody an antibiotic that's going to kill the bacteria, not you. That's obviously really bad. The problem with that is when you're trying to treat different infections, like say a fungal infection or a protozoal infection. So those are eukaryotes. Those are eukaryotes. We're eukaryotes. So if you're trying to target something like cell membrane, we have cell membranes. So those drugs tend to be a lot nastier and have a lot more toxicity to us. They might be effective against the fungus or the protozoal infection, but they have some pretty severe consequences for us too. The ones that tend to work better and don't have a negative impact on us are ones that target things we don't have. Ergosterol synthesis in fungi. We don't make ergosterol, we make cholesterol. Those work pretty good. Peptidoglycan synthesis. We don't make cell wall at all. We definitely don't make peptidoglycan. So those work really well. They might impact your normal flora, but they're not going to hurt your cells most likely. Targeting the ribosome of bacterial cells. Well, the size of the ribosome is different in bacterial cells than it is in eukaryotic cells. So things like that. So that's selective toxicity. So trying to kill off whatever the infectious agent is without hurting the host. The effective dose is the dose at which it's effective against whatever microorganism you're trying to treat. The toxic dose is whatever dose is toxic to us. So what you have to do is you have to look at these in a ratio to see what the risk-benefit kind of reward is. So again, effective dose level required for current clinical treatment, that's what's hurting the microorganism. Toxic dose is the amount that is toxic to us. The way you calculate the risk-benefit kind of ratio is using something called the therapeutic index, oftentimes abbreviated as TI, which is the toxic dose for 50% of whatever population you're looking at versus the effective dose and whatever for 50% of whatever population you're looking at. So let me do a couple of these on the board. Or maybe just one. So TD50 over ED50. I'm not going to put units on. Whatever. So let's say this is micrograms per mil. 5 micrograms per mil is toxic to you. And 1 milligram is your effective dose. That's obviously really bad, right? Because to kill the wait, hold on, sorry, I confused myself. So this is really good, right? So 1 to treat the bacteria, but it's all the way up at 5 to actually have an impact that's negative on you. Does that make sense? So all that to say is if you get whole numbers above 1, good. If you get decimal points below 1, bad. Really, really bad. So let me use the exact same numbers and flip it around. The toxic dose here is 1. But the effective dose to kill the bacteria is 5. Well, you're dead before the bacteria are. So that's really bad. So decimal points, you can't use those drugs. Anything above 1, you could. Obviously, the closer to one you get, like what's 1.1, the effective dose and the toxic dose are really close to one another. There are some therapeutics we use when you get really desperate like that. They have really nasty side effects usually, because effective dose and toxic dose are pretty close to being the same thing, so you start to get sick. Amphotericin B is a really good example of that. You use that sometimes for fungal infections. Clinical pharmacologists usually refer to that as amphotericin B. It makes you very, very ill.
What does it do?
Oh God, I can't remember. I think it impacts the liver, impacts the spleen, it makes you sick, makes you nauseous, diarrhea. I mean, insert the symptom here. It's
So what's the point then? Why don't you just like?
because nothing. It's because they're resistant to everything else. Nothing else is working, and you're like,
Is it-
okay.
There's a chance though?
Yeah, I mean, that it works, but I mean, yeah. I did not change that. Okay, that's what I was going to tell you. Risk outweighed the benefits. This is wrong. This should be facing another direction. I don't know why I did that, but that needs flipped around. Less than one bad, more than one, the further away from one you get good, all right? So that's not right, that needs flipped, okay? Don't let that, I'll try to remember to go online and flip that around, which I swear I did. Can somebody check that actually on Canvas, just to make me,
Yeah, your mine says.
I did fix it on
Yeah.
Canvas?
Yeah.
Okay.
It says risk outweighs.
Okay, so, good. I thought I did it, I just didn't update my PowerPoint. Cool. Okay. We talked about this, but just maybe not me using these words. If the difference in dosage between the effective dose and the toxic dose is far apart, that's good, because you're gonna have an effect against whatever the infection is long before you have an effect on whoever the patient is. If it's narrow, again, it's usually not good. The closer the effective and toxic doses are, the nastier the drug usually. There's an example of some of the ones that have narrow therapeutic indices. Gentamicin, amphotericin B, 5-fluorouracil, which is used to treat some different viral infections. AZT is used to treat HIV. Chloramphenicol, those have narrow therapeutic indices. And for that reason, and that is out of place, people tend to get pretty sick. All right. So how do you determine the level of antimicrobial activity? So there's a couple different ways to do it. You can use something called the minimal inhibitory concentration. So that's the lowest concentration of drug that inhibits the growth of the pathogen. For that to actually be effective in the human body, it has to be higher than this, but one of the ways you determine this, and I'll talk about this in a minute, so I'll just skip forward, is you do something called a broth dilution test. So say you have do different doses of drug with the same amount of bacteria, and you look at which two you don't see any growth in. That's your minimum inhibitory concentration. So for this one, what's my minimum inhibitory concentration? 0.005, right? The one you don't see anything in. So if you go down, and you all kind of already did this, if you go into this tube and you plate some of it, and you see bacteria that grow, is this antibody bacterial static or cidal? Static. If the bacteria doesn't grow, if you subculture this onto a plate, cidal. Right? Not too bad. Okay. So that's the minimum inhibitory concentration. The minimal lethal concentration is the concentration kind of like we just talked about. The lowest concentration that kills the pathogen. And again, there's a couple of different techniques to test that, which you all have kind of done with this diffusion test, because Kirby Bowers is this diffusion test, and the tube dilution test, which is what we just talked about here. The two from which the microbe could be recovered, could not be recovered, is considered the minimal lethal concentration, or MLC. Sometimes you'll also see that referred to as MBC, which means minimal bactericidal concentration. They're the same. It just depends on the textbook. People usually use MLC now. MBC is a little more antiquated, but they mean the same thing. So if you have this tube here and you recover bacteria out of it, but you go down to the next tube and you don't, that next dosage would be the minimal lethal concentration. Kirby Bauer, you've done. You're looking for zones of inhibition. You measure that zone of inhibition. There's a table you go to determine if it's sensitive resistant or intermediately resistant. So you've already done that. Okay. So the greater the minimal inhibitory concentration of the drug required to inhibit the growth, the greater the microbe's resistance to that drug. So if you look over at this little chart here, you have the minimal inhibitory concentration over on this axis, 0 up to 256, and how big the zone of inhibition is over here. So if you look at this graph, which one is more resistant? A or B? A, right? Because it's a much higher dose. You're looking at 128. Sorry. You're looking at, oh god, 28 versus 17. Sorry, 28 versus 7 for the dose, and the zone of inhibition is about 11 or 12 versus 17. So bigger zone, generally, bigger zone, more sensitive. That does not always hold true if you're looking at different antibiotics are different sizes, they diffuse through the media differently, yada, yada, yada. But if you have a bacterium and it grows all the way up to the antibiotic disc, it is resistant to that antibiotic because there is no zone of inhibition, and sometimes you see that. Usually if there's a zone, it means at least there is some sensitivity to it. Is that enough to actually treat the patient? That's why you use these clinical interpretations like a table where you measure the zone of inhibition, the diameter, and see if it's going to be efficacious. All right. Talked about this. So you can change different functional groups and things to change the effect of the drug. You have to look at things like therapeutic index. And so oftentimes if you even change the functional groups, you can even change maybe the therapeutic index a little bit too. It might make it more effective. It might make it less toxic to us. So by changing little functional groups and things around, like carboxyl groups and hydroxyl groups, you can change the effect of some of these drugs a little bit. What you can also do is you can add inhibitors. So penicillin is a good example of this. So there's some bacteria that make enzymes that actually break down the antibiotics themselves. So what you can do is with that antibiotic, you can add an inhibitor that inhibits that enzyme from breaking down the antibiotic. If it's with penicillin, it's usually something called flavonoic acid. That is a inhibitor of those enzymes. Actually, never mind. It's a competitive inhibitor. It goes after that instead. Enzymes goes after that instead of penicillin. But yeah, it blocks that enzymatic activity. It's a competitive inhibition technique. Variables that influence drug effectiveness: ability of the drug to reach the site of infection and get into the tissue to penetrate the bone. The example I think I might have talked about in here before: you have somebody that has meningitis. You don't have a lot of immune cells around your central nervous system. You shouldn't have any bacterial cells in there either, but you've got bacterial cells, they got the blood-brain barrier, they cause inflammation, and they found their way into your central nervous system, maybe cerebrospinal fluid. If you're trying to treat meningitis, you have to use drugs that have the ability to cross that blood-brain barrier where the infection is. If they can't penetrate that blood-brain barrier, they're not going to do it. Because they're not getting to the site of where the infection is. So you have to look at the ability of the drug to reach the site of infection. You have to look at the susceptibility of the pathogens to the drug, obviously we talked about that. If it's an antibiotic that the pathogen is resistant to, it's not going to work. So you have to look at that. You have to look at the ability of the drug to reach concentrations in the body that exceed the minimal inhibitory concentration of the pathogen. What's that mean? you have to look at clearance. So you have to see how fat does your body, like, say it's something that goes through the kidneys. Do the kidneys filter this drug out of your body faster than what it can actually reach the effective dose to actually treat the bacteria? Some antibiotics, your body's really good at clearing out. So you have to look at that. You have to look at the route of admission. Is it oral? Is it intramuscular? Is it intravenous? Is it a systemic infection? Maybe it's something you want to give an IV for versus something oral you have to wait for it to be absorbed. Depends on what you're looking at. What's the dosage? Where this comes into play is like when you do, obviously it comes into play when you're trying to treat somebody, but it also comes into play when you're trying to develop therapeutics. So if you go to the FDA and it's just like, hey, I got this cool drug that's effective at 9 grams per like milliliter, it's like, that's not gonna be, it's like a massive amount of drug. The chances of that not doing something to the human body, pretty low. They usually look for like nanograms or maybe microgram kind of level of infectious or effective doses. So if you have something that's effective that's in a really, really high dose, those usually aren't effective, or effective, like you said, effective. Those usually aren't effective for treating infections, at least not internal infections. Things that have high dosages like that, you tend to see in things like Neosporin, things like that are topical. And if you try to take some of those internally, they do very bad. That's why you use them topical. Because the dose is high and they move things up. Rate of uptake by the system, so how fast does your body actually take this up and gets it to the site that you want to get to. And again, kind of like I talked about at the beginning of this, how fast does your body clear from your system? Because if it clears it faster than what you can reach the effective dose to actually treat the bacterium, it's not good. All right. No. 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 There we go. These are all talking about some of the different antibiotics we're talking about. You do not need to know all those from those figures. Let's just hit the ones that we need to know. You don't need to memorize those tables for the love of God. Do not memorize all those figures and tables. There's more antibiotics there than what you need to know. We'll just focus on some of the key ones. So, there are sulfa drugs. They are bacteriostatic, so it's important to know if they're cytostatic and what their mechanism of action is. So those are sulfonamides, but again, oftentimes we're just referring to these simply as sulfa drugs. They are anti-metabolites. They are broad spectrum, which means they cover, you can use them to treat a bunch of different things. They are synthetic, so they are naturally occurring antibiotics, semi-synthetic antibiotics, which are the natural ones where you change the functional group or something, and then there are fully synthetic ones. A fully synthetic antibiotic means I made this in the lab. It didn't come from a fungus, it didn't come from a bacterium. I made it. I put all the carbons together. So that's the difference. This targets folic acid synthesis. Ultimately, folic acid synthesis in bacteria, what all this folic acid synthesis catabolic processes eventually feed into is DNA synthesis. So if you shut down folic acid, you can't make DNA. Way down the chain. But ultimately, that's what it ends up impacting is DNA synthesis. Mixtures of these antibiotics tends to be more effective. Sulfamethoxazole, trimethoprim, collectively is referred to as Bactrim, and you can use Bactrim to treat different kinds of infections. The problem with this is some bacteria have figured out ways to get around this. What they do, instead of synthesizing folic acid, they just have figured out ways to take up folic acid. So like, okay, you block me making folic acid, I'll just take up folic acid. So they become folic acid oxytropes. See how it comes full circle. But they become folic acid oxytropes a lot of the time. Then you have some other synthetics, quinolones and isoniazid. That's what NIH is short for. They inhibit DNA synthesis, particularly by impacting the DNA gyrase. DNA gyrase is what makes the DNA negatively supercoiled. For all intents and purposes, it's an enzyme that makes the DNA really compacted. If new cells can't get really compacted, you can't make new cells. So it's essentially involved in compartmentalization of the DNA into a tiny little area so it can fit inside the bacterial cell. If you can't compartmentalize it, is that the right word? Compact it really well, it shuts down any new cells ultimately. Fluoroquinolones are an example of this, ciprofloxacin is an example of this. Again, some of these things have different kinds of side effects. Tendinitis, tendon rupture, muscle weakness, all these things, they are drugs that sometimes, if they're naturally occurring, microorganisms made to kill other things, so they can sometimes have some nasty side effects. So those are quinolones, those are broad spectrum. Isoniazid is a narrow spectrum. It targets glycolic acid synthesis, so it's only going to be effective against things that make glycolic acid. So all the gram negatives and gram positives we talked about, it's not going to do anything. They don't make glycolic acid. Tuberculosis, pretty effective against tuberculosis when you use it with other antibiotics. Tuberculosis is known to become resistant to things really easy. You usually use something called a combination therapy to treat those patients with about 2 or 3 different things, all with different mechanisms of action, because the chances of a bacterium becoming resistant through mutagenesis to all 3 of those different antibiotics with different mechanisms of action is super duper low. Becoming resistant to one, super duper high. So that's a narrow spectrum antibiotic. Don't worry about atypical mycobacterial infections. For those of you who have path, we'll talk a little bit about those. There's other mycobacterium, other species, I should say, mycobacterium besides tuberculosis, and a lot of those other species cause skin and soft tissue infections. Some pretty penetrating infections. There are polypeptide antibiotics. They impact the plasma membrane. Basotracin is an example of that. It's toxic internally, so you use it topically. That's one of the ones I was talking about. It's effective in a high dose. Internally, it starts going after your plasma membranes too, and can not have a good outcome. So you use that topically. Polymyxins increase membrane permeability of gram negatives. They act like detergents. Another one you use topically, usually used topically. Some of these if you have an organism that's resistant to a lot of different things, like say it's resistant to literally everything else, it's extensively drug resistant or pan drug resistant, sometimes there are some off-label usages for some of these where if you have no other option, you could start to use them. But for the most part, when you talk about things like polymyxins, those are topical because they don't play nice with us. Alright? Mixtures are more effective, basotracin, polymyxin B, phencyclidine, polysporin. That's what's in polysporin, is all these 3. So when you mix them together, they tend to work a little bit better. We talked about this essentially already. Penicillins, those are generally narrow spectrum. They inhibit peptide glycan synthesis, so the bacterial cells can't make new cells. Those tend to obviously then be more effective towards gram positives because gram positives have more peptide glycan than gram negatives, so they tend to work better on gram positives. They contain beta-lactam ring. Problem with that is some organisms have figured out how to make a beta-lactamase. Beta-lactamase breaks down the beta-lactam ring. So you have to add sometimes to these penicillins a beta-lactamase inhibitor. And essentially what that is a mimic. It looks like penicillin, so the beta-lactamase tries to target the mimic, and it leaves the penicillin alone. And then the penicillin has a better chance to work. So that's a beta-lactamase inhibitor, things like glycolic acid, which I think I have over here on one of these slides somewhere. We just haven't quite got to it yet. There are some newer, broader spectrum, semi-synthetic penicillins where they've added different functional groups. They tend to be more resistant to stomach acid and cause fewer allergic reactions, because remember, there are a lot of people that have penicillin allergies, and those include things like ampicillin and amoxicillin. Again, if you mix these with beta-lactamase inhibitors, they tend to be more efficacious, and the bacteria tend to not be as resistant to them. And then you have cephalosporins. I'm going to fix my title on that too. There's 5 generations. First, second, third, fourth, and fifth. They've changed different functional groups on them. They've messed around with them a little bit. And when you do that, it changes what they have effectiveness against treating. So what does that mean? First generation cephalosporins were pretty much just for gram-positives. Second generation, it started to actually be used against some gram-negatives, and it was effective against those two. Third generation, pretty much only worked against gram-negatives, not really gram-positives. Fourth generation, worked against some more gram-negatives. And then fifth generation actually starts to include MRSA, and MRSA is a gram-positive. So if you start to change functional groups and stuff, it changes what's effective again. That's all they've done here. And the higher the generation, the newer it is, that's pretty much all that is. And so blocks cell wall synthesis, cephalosporins, beta-glucan synthesis. Vancomycin is another antibiotic. It's narrow spectrum. We tend not to use it unless we're out of options. I say that knowing that a lot of people use it when there's many other options, but you're not supposed to use this unless you're kind of out of options. When I was up, I can't tell you where it was, maybe that's probably bad. When I was somewhere else, for whatever reason, the protocol was to have paramedics, to have EMS, pretty much anybody that stumbled into the back of an ambulance got a shot of vancomycin. They stopped doing it, I think I raised so much. For whatever reason, they're like, oh, well, vancomycin is a good treatment for different things. So if somebody comes in and it looks like they might have a boo-boo owie, we're going to give vancomycin so they don't get sick. It made no sense. I mean, you have people who walked in the back of the ambulance because they broke, like they got in a car wreck or something. They're like, vancomycin, like, what do you do? And so it's supposed to be a drug of last resort. It does have negative consequences. It can damage the ears and kidneys. You can administer it through IV. It's used for like serious gram-positive infections. Inhibits peptide cross-linking in cell peptidoglycan, which is a long way to say it blocks peptidoglycan synthesis, just like penicillins and cephalosporins do. Vancomycin comes from vanquish. You can use it for some nasty gram-positive infections. We'll talk about some of these too. Tetracyclines are going to block protein synthesis. So remember, the ribosome and bacteria are different from the ribosomes and eukaryotic cells. So it's going to target that difference. Tetracyclines are synthetic derivatives, but the core molecule is from a naturally occurring antibiotic. So they would be semi-synthetic. Broad spectrum activity, you use against chlamydia, rickettsia, mycoplasma, and some other things. Binds the 38 subunit of ribosome. It's considered one of the really effective drugs with penicillin, streptomycin, and chloramphenicol. That's why it's called one drug. Aminoglycosides are another one that's going to target protein synthesis, target another one, targets the 38 subunit. It can cause misreading of mRNA during translation. Essentially, it adds so many errors into mRNA synthesis that the cells start to not be able to make effective proteins for the functions that they're supposed to be actually carrying out inside the bacterial cell. So the bacterial cells don't make it. There's some side effects to those as well. Some different examples down here: streptomycin, gentamicin, neomycin. Neomycin has a poor internal absorption, so this is another one that kind of comes in as a topical because your body doesn't absorb it well. So you use it for topical treatments for like cuts and scratches and things like that. Gentamicin you can use to treat UTIs. Usually we don't use that. We use other things like ciprofloxacin. Sometimes people use Bactrim. That tends to not be super effective. But usually gentamicin is not used a ton to treat UTIs anymore. On occasion you see it, but not a lot. Reason being is gentamicin has a narrow therapeutic index. It's not a really friendly drug to our system, so people tend to shy away from that a little bit. It can cause damage for that reason. It can cause damage to kidneys and even potential deafness. So again, that's one of the ones not so friendly with us necessarily. Streptomycin, it was used against tuberculosis. And again, anytime you're treating tuberculosis, that's a combination therapy. And that's why that one bullet point says you usually use it with like isoniazid or something else. If you try to treat somebody with tuberculosis with one antibiotic, they're going to become resistant to it, most likely. And they're still got tuberculosis. Alright. Macrolides are another one that target protein synthesis, except instead of targeting the 30S subunit of the ribosome, they target the 50S subunit. Erythromycin is an example of this. Zithromycin is an example of a semi-synthetic macrolide. Erythromycin can be used against gram-positives and gram-negatives both. It's a broad spectrum bacteriostatic antibody. So this is one of the ones you would give somebody that doesn't wipe out an infection, but it keeps control of the amount of bacterial cells that are causing infection, so your immune system has a fighting chance of wiping them out. Chloramphenicol is another one that has a narrow therapeutic index, so it can have some negative side effects too. And it's another one that targets protein synthesis, providing 50S subunit. It's broad spectrum, has a good penetration, so it's actually able to get inside the cells. And the problems with it is, again, because it's one of the ones that has a narrow therapeutic index, it can cause things like bone marrow suppression. So why would bone marrow suppression do that? Whoa, what happens in your bone marrow? Yeah, right? So, yeah. It's narrow therapeutic index. It's gonna harm the bacterial cells. It's gonna harm you too. In that case, it's harming your immune response. And you have an active infection. So not really the thing you want to be targeting. Do you use that sometimes? Yeah, when you're real desperate and nothing else is working.
Do they get bone marrow transplants? It's like, is it in the,
I mean, if you're,
how much is it suppressing us completely? Like, you just.
because the process of actually giving somebody a bone marrow transplant, you're actually opening out an infection by giving them the bone marrow transplant. So trying to do that might be worse. Like where you're going with it, but not necessarily. Yeah.
Do they, like, is the bone marrow, like, does that suppression
Yeah. I mean, when you take the chloramphenicol away, assuming you get rid of the infection, yeah, it will come back. It's not permanent, but I mean, yeah. Bone marrow, so that's where B cells are being made, B cells, plasma B cells make your antibody. I mean, that's a pretty big component of your immune response. If you suppress that, the different things you see there that you can kind of use to chloramphenicol to treat meningitis. Why meningitis? Because that's one of the ones that has good penetration against the blood-brain barrier. It can get in the central nervous system. So I mean, it works. It might mess up some things too along the way. Typhoid and typhus fevers. Typhoid is salmonella. We talked about this in here a little bit. Salmonella, enterica, cerebrotiphi, paratyphi, and Salmonella, enterica, cerebrocholera suis all cause disease processes that look like typhoid fever. So they cause rose spots. Do they cause diarrhea or do they cause constipation? Constipation. So you use it to treat that. You can use it to treat that, I should say. I talked about typhus fevers in here, right, too. Those are like a bunch of different things. Essentially, that's an infectious agent that's transmitted through something like a flea or a tick or a chigger bite that causes a fever. This is the big group, and they lump them all in alcohol typhus. So you can use it for those things. Rocky Mountain spotted fever, you can use it for that. That's caused by the capsule species. We talked about Rocky Mountain spotted fever too, right? A little bit. So I mean, that's one of the places where you can get a little bit desperate. I mean, maybe somebody has really bad vasculitis, they're starting to lose digits. Rocky Mountain spotted fever, if you don't treat it fast enough, it will kill you. So if it's been allowed to progress long enough and you didn't catch it with Rocky Mountain spotted fever off the bat, and you're getting to the point where you're getting to that point, maybe you want to pull out some chloramphenicol. So again, you're desperate times for that usually. We might have talked about this before. We've known that bacteria can become resistant to things all the way back since the 40s when Fleming discovered penicillin. He knew it, and I've talked about how that happens. You take a bacterium in here that's not resistant to, I mean, we're talking about penicillin, let's say penicillin. You take some bacterium that isn't resistant to penicillin, and you put it on a plate that has a little bit of penicillin in it, but not enough to kill it. Eventually it will start to select, or you will start to select for bacterial variants, so mutants of that, whatever that bacterium is, that has some kind of mutation in something that makes it resistant to penicillin. And then you can take those bacteria and you can start to increase the dose of penicillin, and the longer you kind of draw that out. I mean, I'll give you an example. I have bacteria in the lab. You don't use ampicillin to treat it, so it doesn't really matter, but it's resistant to like a gram per mil of ampicillin. I mean, you can kind of make it resistant because you're positively selecting for the mutants if you do it long enough. This one's probably a little bit scary. What has happened over the years is what we've seen is initially, for the most part, a lot of the antibodies were discovered a long time ago. From when they were discovered to when you started seeing the first cases of resistance being documented, it was like 15 years, 20 years. Now, antibiotic hits the market, 6 months later, you start to see resistant isolates. More people, more treatment, more selection, things have gotten worse. So we give the examples of that. Where do you have? So we can look at penicillin, I guess. Let's look at streptomycin. That's a little bit better example. Streptomycin came out early 40s, and you really didn't see cases of streptomycin resistance until almost the 60s. It's a decent amount of time. Then you go down here. Daptomycin, 2004, 2005. So we're getting in kind of a bit of a little pickle here.
Why do you
So,
think there's such a high, like a quicker resistance to antibiotics?
a lot of these things come from naturally occurring, well, there's a lot of reasons for that. A lot of these things come from naturally occurring antibiotics, so they've been altered in some way. So they have a different functional group put on them, slapped on them or something. So they have existed. A lot of these organisms have seen them in some fashion. So you have more people that are, you have a higher population, which means just statistically more people are going to get sick. There's more people that's going to get treatment. Some of those people get treatment when they don't have a bacterial infection. They go with a stuffy nose and they get pumped full of whatever. It's not going to treat the infection because a lot of times it's viral. I don't usually talk about this in here, but sometimes you see some of these antibiotics that they put in like food for livestock. And they're like, oh, we never used it to treat people. Let's use it for that. It's like, yeah, but you've been feeding it for cows for like 20 years. So things have seen that antibiotic, so it doesn't take long. Like I can't remember what the drug was, but there was an antibiotic they put in livestock feed over in Europe for years. And then over here we're like, oh, we gotta hold that one back. So in case we ever see something, we can use that. It's just like, dude, has anybody ever flown from like London to like New York? Like it's here already. Like there's resistance to it, and there's resistance to it. For whatever reason, one of the things they have done, and it's starting to get a little bit better, is they love to put antibiotics in food for livestock because they're afraid if like a herd of cattle gets sick from some kind of bacterial infection, they're gonna lose a lot of money. So they're like, well, let's just put antibiotics in all the food like prophylactically, and then they'll never get a bacterial infection because I mean, they're more antibiotic than cow at this point, so it'll be good. Well, yeah, but I mean, you know, I mean, you're exposed to a lot of organisms to that antibiotic, so yeah. And then potentially you might consume that antibiotic too, which is also going to expose you to it as well. Or you consume bacteria from the meat that we're exposed to. Fun times. So some of the general mechanisms, we talked about this stuff before, somewhat. So how does bacteria become resistant? Lowering metabolism, entering a dormant state, so there's some bacteria that can do that. They essentially go into almost like a state of stasis until the antibodies are removed and they start growing again. They could generate a biofilm. When they generate a biofilm, they become super resistant to antibiotics. They could switch to a different like compensatory pathway. So what that means is say you have, say you have in the bacterium, you have some kind of a cyclical pathway, like Krebs cycle. And you have, let's see, you have a cyclical pathway, and you make an antibiotic that blocks this reaction from happening. What a lot of bacteria have figured out a way to do is they'll just do that and just skip that step. They'll select for mutants that actually have figured out how to go from this compound to this compound. So who cares if you're blocking something down here, because it's not even doing that anymore. They're very good at doing that. Those are called like shunts, different things like that. Like an alternative pathway. Sets of comps for that mechanism. Increased production of metabolites. This one too. So it's like, okay, I'm going to target synthesis of this. Those make a lot more of it. So who cares? Actively pump out the antibiotic. This is a big one in gram negatives. And I think I talked about this in here before too. So what happens with gram negatives sometimes is they'll take in antibiotics into that periplasmic space, and then they'll just pump it right back out. Sometimes you get mutants that are heteroresistant, so pathogenic cells of infection have point mutations due to genetic drift, like we talked about before, so like little slight mutations in the targets of the antibiotics, and it makes those cells resistant to it. Oftentimes, heteroresistant colonies, if you're doing something like, you did Kirby Bauer, so you'll understand what I'm talking about here. If you do a Kirby Bauer test and you see that disc you put on the plate, you have a big zone of inhibition around it, and in that zone of inhibition, you see like teeny tiny little like pinpoint colonies. Those are heteroresistant isolates typically. They've had some little genetic shift, some little point mutation or something that's starting to let them become resistant to whatever that antibiotic is. So if you ever do anything clinically, or if you're in a clinical micro lab and you see a zone of inhibition has little tiny like pin prick kind of colonies on it, those are not good. Those have figured out a way, or started to figure out a way to get around some things. You know that drug resistance can be acquired through horizontal gene transfer, lowering metabolism, interconformal state, like we talked about. I don't know why that's like in that order, but different mechanisms that allow different genetic material to be picked up, and that genetic material could carry a resistance gene. Mutations of chromosomal genes, usually in the drug target itself. You can take up R plasmids, the bacteria takes up R resistant cell plasmid, has resistance genes on it. You could have resistance genes on jumping genes called transposons. Sometimes they can be carried by phages, resistance can be carried by phages. Or you can have huge big gene cassettes where there's whole big sets of different resistance genes that are carried in mass on the gene cassette, and that can be carried by transposons, plasmids, chromosomes, what have you. And then sometimes you can get something called a superinfection, which I believe we talked about in here, but I've never actually used that word before. Inadequate drug treatment destroys only drug-sensitive strains, and what happens is, I don't know if I've drawn this on the board for you yet, a couple things can happen with a superinfection. So you have these bacteria. You treat with antibiotic, you're supposed to be on for 7 days. Yeah, you feel better in 3 days. Whatever. You stop taking antibiotic. All these circle ones are sensitive to the drug. This one, represented with the X, has some kind of a point mutation or something that it's resistant to that drug you're taking, or starting to become resistant to that drug you're taking. If you take it for 7 days, it wipes out everything. If you only take it for like 3 days, it wipes out all these and leaves that guy. When you take the antibiotic away, this guy turns into this. Well, not that guy. Maybe that guy too, but it's gonna, and then it doesn't have the other cells there to even compete with necessarily. By the same token, you can take something like an antibiotic, say, like a doxycycline or something, it's known to do this a lot. You take doxycycline, it wipes out a bunch of flora in your gut. It leaves things like Clostridium difficile, and then you get Clostridium difficile infection. So superinfection is wiping things out and leaving the bad things behind, ultimately is what that is. that's either normal fluorides wiping out and leaving things behind like Clostridium difficile, or wiping out drug sensitive isolates and leaving the resistant ones, and or both. So that's a super infection. Alright. Makes sense? I don't feel like this was too bad. You don't want, I mean, I know it's like a ways off, but do you want me to like